this wasn't necessarily in response to COVID, but certainly was seen as one of EPUT's critical projects to continue with as a result of the demand that was likely to come as a result of the COVID crisis for mental health. The ask itself presented EPUT with a number of challenges in regards to how do we integrate and bring together what is a pan-Essex mental health crisis service when historically it was relatively separated, very differing approaches across CCGs, and to add to the mix, having to channel that via the 111 providers who obviously have their own sets of governance and controls, et cetera, and because it was 3 CCGs, typically 3 separate 111 providers to try and negotiate with. I think that posed a number of sort of communication negotiation challenges, but even once we'd achieved or got to a point of being able to have a single pane of glass for how patients contacted us, we still needed to offer the same continuity of how our clinical systems would react to a patient who could call from any one of the 3 service areas, be channeled through, as Jan mentioned, our clinical contact centre, and then be triaged successfully via a 2-stage process between our contact centre and our clinical triage team. Because EPUT had quite a mature contact centre in place already, we already had a good front door to be able to deal with a patient who was used to speaking to the contact centre, and likewise the contact centre staff were already familiar with crisis patients. The intelligence that we added on top was to take the telephony platform, a product called Cisco UCCX, and overlay it with a clinical dashboard, effectively an electronic form set that pre-populated itself with information presented directly from the phone system itself. It was the first time that we'd done this, and we managed to get some good support from Cisco directly, who were very interested to see how well this could work, to passing telephony data directly into a clinical system to do patient lookups and do validation, so that we were in a position where a crisis patient who, by the very nature of crisis patients, wouldn't necessarily be coherent, wouldn't necessarily be giving their information or correct information, but we might know who they are before they've even spoken a word, by looking against our patient record system, taking the information taken from the telephony platform, plugging that directly into the system and bringing up potential hits for that patient without them even necessarily announcing themselves. That immediately became one of the huge value adds that we could have between marrying the technology and the clinical contact. Taking one step further, we evolved the electronic form, turned it into an electronic dashboard that then allowed the contact centre to provide a frontline semi-clinical triage by being able to be in a situation where they understand the patient's current situation, whether they're known to the service or not, displaying a summary care record to understand whether there's any open episodes, any history, anything that we need to act upon, and then be able to route that patient directly to the respective crisis team, where the crisis team themselves were having to operate as a clinical contact centre. So the contact centre agent announced the information to the clinician while the patient is available on the call, and pass the patient directly to the clinician, who immediately had at their fingertips all the information that had already been gathered, that had already been searched into the system. So there was no need to then go through the same rigmarole, the same process of trying to gather information, identify history, etc., etc. In effect, we used the telephony system to drive a patient contact experience. I think the success behind that meant that we met some KPIs that have been defined to us by the 111 providers themselves, in the sense that we almost became a 111 provider in our own instance, gave the patient experience of being able to dial 111, press 2 for mental health, which was the negotiated platform we managed to have with all 3 providers, which took some doing, and within 60 seconds they'd be speaking to their mental health provider. We'd improved their journey and the patient experience as a result. What became some of the real lessons learned was that we perhaps didn't consider the cultural change that the clinicians themselves were going to have to go through. The biggest challenge being that a clinical workforce experience of working a certain way was suddenly asked to operate as a clinical contact centre, which meant their management, their supervisory parties needed to be cognizant of the fact that they needed to be logged into the phone system at a certain time to make sure they're able to take calls. Calls were being handed to them with them having, I think, on a 3-ring notice, which took some getting used to. That learning curve was very steep, but ultimately very successful. And I think second to the cultural implications, the KPI learning, building the system around the KPIs rather than trying to do it vice versa, was another lesson learned. We had to do this at pace. Obviously, the pandemic itself meant that yes, we went live on the day we wanted to go live, but of course in the middle of a pandemic makes it very difficult to make any service live. But we used the technology like we're using today to offer training. We managed to almost simultaneously launch Teams alongside the Crisis 24 service, which meant we could use one technology to support the other, and actually offered online training via Teams to the clinicians, who pretty much wedded themselves to it for about a fortnight period as shifts changed overnight. And yeah, as a result, produced some really good successes and some statistics that CCGs were very pleased with.
Once they've finished their assessment and their notes, it automatically updates the correct patient information system, because we have several across the organisation. And also we managed to integrate our sanctuaries and our crisis cafes that were across Essex. So we've enabled them to use Accurix and Teams and Tend Anywhere. And also they are a direct referral through electronically, so they also have access to that patient data. So we've got that as a two-way flow, and has been really successful.